we will start this session, cataract session 2, about fields in cataract surgery. I'm very happy to share this with a very prominent faculty, and we are going to start to try to be on time by Dr. Dorval Carvalho, Jr., talking about 5 fields in small pupils.
For me, it's a great pleasure to join you this meeting. I'm president of the Brazilian Association of Cataract and Refractive Surgery. It's a very proud for us. Today we are talking about the small pupil. 5 pupils in a small pupil. Okay.
It's clear. The sharing is perfect.
Okay, thank you. Let's start. Well, first of all, I usually use the non-steroidal anti-inflammatory drugs, eye drops, before surgery. We start to use 2 days before surgery, 3 times a day. In cases that we have diabetes, uveitis, I usually like to start before, maybe 1 week before, and it's very helpful to avoid amaurosis intraoperative. So especially in cases when I use the femtosecond laser. So I use in all my cases, I use the non-steroidal eye drops before surgery. This is the most used in Brazil. We have the Cataract trometamine, 0.5%. The second, we have to avoid enclosing the pupil during the surgery. So this is very important, mainly in the beginning surgeons. So I changed my surgery to avoid this. So I used to refill the viscoelastic substance during the surgery, mainly for capsulorhexis and capsulotomy. I use sometimes I dilate the pupil with viscoelastic. The other parameter that I changed, that you have to lowering the intraocular pressure to avoid the flow in the anterior chamber with the decreased bottle in some cataracts in a phaco system, or with system with positive irrigation. I set up the IOP for less than 40. So I working with the IOP about the 32. It's work very well, and you avoid the iris prolapse. So it's very important. You have not to use a wide incisions. You have to avoid the wide incisions. You have to it's very important to tight incisions. So you have to pay attention with the blade incisions to your phaco tip. Yeah? You have to avoid to touch the iris during the surgery. Aspirate with the phaco tip. It's very damaged to the iris, and start to close the pupil. And in high myopic patients and vitrectomized patients also, you have the iridocapsular diaphragmatic block. So you have to avoid this maneuver, this phenomenon, and irrigation behind the iris. Before to start the irrigation, you position the phaco tip, the irrigation tip, under the iris. So this distributes the flow during anterior and posterior chamber, and you don't have this irido-capsular diaphragmatic block. And you have to improve the intraoperative with a small pupil. You sometimes the small pupil is not so much, and you can use you can continue the phaco surgery with a small pupil. What the tips that you have? You need center the phaco tip on the iris plane or posterior. Low IOP, the same of that I said. Low parameters, low flow, low vacuum. So this will help to avoid the meiosis. Avoid the movement of the tip. You just to keep in the center. And this is not for hard cataract or some challenging cases. This is for soft nucleus. And sometimes you can use with a small pupil. But if not, this is not success with all these tips and the pupil close. You must have to use the adrenaline drug intraoperative. It will be helpful to open the pupil most of the time. It's very helpful. But if you're not of this working, you have to use the expanders of the pupil. We have today many of that. But starting with the iris hook, I think it's the most popular. You have to do 4 micro side ports to expand the pupil. But it's not. You have to spend more time to implant this 4 iris hook. So and the pupil is like a square, like a TV screen. So not is so physiological appearance. So they developed so we also have the Malugin ring. That is you have to the same expand of the pupil, but you don't need to use the side ports. So that's very advantage. So you inject this ring and help you a lot. So you avoid the side port incision. But the problem is that in these expanders, you make a square design, like a TV screen. So to becomes better with they developed the new expanders, but a circular expander. So it's more physiological for the surgeon. Expand all the system. Another ring, not foldable, but it's very useful, is a Canabrava ring that you position those tips, sticking the pupil edge between these stitches.
1 minute.
So it's a very useful and works very well, this Canabrava ring. But now you have the injectors in flexible rings, like this sold by diamond manufacturer. So this is a flexible expander ring. He manufactured. This is an injector. So this is a metal material and flexible, and you can use several times. It's like a speculum. No? This is when you inject, you are positioned this expander, and you adjust this expander with the pupil, and it works very very well. So now you have the one larger pupil, circular, and it's very helpful to do all your cataract surgery with safe. And the same way you can take out the expander. It's easy, not difficult. Okay, this is another case. You can use sometimes in the capsular bag. It's possible also. It's another pupil expander. This is eye ring from BriviEye. This is the way that you load the expander. You start to inject. It has a trail to set the pupil edge, and you adjust its sides, and it's very interesting instrument to enlarge the pupil, and you can do the phaco surgery in the same way that you do with the large pupil. It's a very nice tool to the cataract surgery. I'm finished. And the same way you implant the intraocular lens at the end of surgery with the injector, you can remove the eye ring pupil expander. Sometimes after the surgery, the patient, the pupil was dystopic, is decentered, and we do the iridoplasty, laser iridoplasty. It expands the pupil if you need. This is a case with the opacity in the upper third of the cornea, and we did the iridoplasty, laser iridoplasty, and enlarge the pupil. Sometimes the small pupil is good. The patient with photophobia.
I think you have to wrap up, Dr. Carvalho. We are exceeding the time.
Yes,
So
yes, I've just finished.
Okay.
That's
Mhm.
okay. Okay, this is my. I thank you very much to participate, and I hope we can discuss that. Thank you very much.
Thank you very much for excellent presentation. We are sorry that we have to interrupt just because we are limited to the live transmission. So thank you very much. Excellent. And I think we can have a lot of questions once we move on. And we will have now Professor Ahmed Ghunaim. who's a great surgeon and dean of Faculty of Medicine, Tanta University. And he's talking about 5 peels in capsulorhexis. Dr. Ahmed, please.
Thank you, Dr. Salah. Welcome, everybody. Can you hear me well?
Yes, perfect.
Thank you. Thanks, Dr. Yahya, for this, for inviting me for such a nice meeting. I'm talking about the rhexis, mainly the principal and basic techniques. The making of a continuous circular tear in the anterior capsule during the cataract surgery to allow the expression or fake emulsification of the nucleus and the lens. The capsulorhexis is mainly the most important part of the cataract operation. We know that because the anterior capsulotomy dictates how the rest of the procedure will go. So when I finish the rhexis, we can say that the most difficult part of the procedure is over. So we all know that rhexis or the capsule is a like a cellophane. So when you have a just very small tear in it, you will lose its power. You can see how much I have to press to hear this click. It's difficult to tear from the smooth margin edge. So the eye rhexis opening should be circular, well-centered, 5 or 5.5 millimeters, smooth, continuous, to resist the tearing during the manipulation of the nucleus. Also, should be centralized, regular, without flaps. And it should allow the placement of the IOL in the capsular bag, prevent the anterior displacement of the lens, preventing PCO, allow the easy lens exchange in the bag, allow sufficient room for easy phaco, and prevent phimosis like the photo we can see now. So by using corneal diameter mark, we sometimes use an optical zone marker on the cornea, helps to judge the side of the capsulotomy and its position. 5.5 millimeter capsulotomy use a 6 millimeter optic zone marker. So we have to inject high viscosity viscoelastic with low viscosity with a good cratome incision, trying to create the cystotome as we see here. It shouldn't be vertical, so you can see the near edge of it. It should be obtuse angle, so when you put it in the eye, like here now, I can see the tip. Sometimes I can do here. We can see how to bend the. If you use the cystotome, and they make another bend, and the second one in the center, to help you not to press on the posterior edge of the wound, not to lose your viscoelastic from the anterior chamber, and also it should be obtuse, so your finger or your hand cannot prevent viewing the edge of the cystotome. So now I'm just making step by step. You can make it in more and more stations for the beginners, maybe, or we can use it just very rapid in 1 or 2 stations. When you find it's going away or run away, you should collect it to the center until you can complete your rhexis. Sometimes I can do the rhexis on a saline. Sometimes I use it if I can't see well, if I don't have a stain, or if I don't want to use a stain because of the endothelium or something like that. I just depend on floating of the rhexis, of the capsule, just floating in the anterior chamber. I can see the moving, so I can just press it and press it again and again until I continue. Using the rhexis forceps, it's better to use the curved one, because the straight one just make you touch or just to press on the posterior lip, so you can lose more and more viscoelastic. But now here we can still keep the formation of your anterior chamber. You just make a snip. You can do it clockwise or anti-clockwise. You just have a small grip, and then you can do it in such stations, 1 or 2 or 3. And you can judge your direction of your hand if you want to widen this area or just go closer or go narrower as you judge your size. If the tears begin to radiate upward, stop, go outside and just inject more and more viscoelastic, then just direct your hand against the direction of extension. Like this case, we can see you just push in this direction against the extension, you will find the arteriorexis is completed. Like here also, you just go, and then when you find you have some extension, you can go against the direction of. So in a special situation, if you have an absent trade reflex, you can use, I always use better to fill with air. Be sure that you have just one big air bubble, because if you have more and more air bubbles, that means you still have some aqueous in the anterior chamber. I use the stainer as a cystotome stainer. I don't like to wash to the stain. I just inject viscoelastic. It helps to stain more and more to the anterior capsule, and just have a small snip. You can continue with your cystotome, or you can use your rexes, and you can use such spiral rexes in 2 steps or 3 steps in white cataracts. You can do it spiral, so you can judge the size, and when you find that the rexes is running away, like in this case, you can see here. So to avoid this, or to avoid the Argentine flag sign, you can do your rexes in such a way, carefully, like an orange. Take your time, because maybe the most important step in this case is doing the good rexes. Sometimes the rexes, you can need to cut the rexes and do it in 2 steps, because it might just rotate upon your rexus forceps, so you can direct it. You can by your hand direct it in an opposite way, so you will lose the continuity of the rexes. So it helps you to just free some of the free lens matter, or to just evacuate what's inside. Sometimes we have a calcified capsule, like in this case. You just make a stain and know that the elasticity of the capsule in the area between the fibrosed area and the normal capsule, you can find that you have to make more and more stretch on the zonule, so be careful. It depends on the age of the patient, so you have to be very patient until you can work in the normal area. And sometimes you can find what we call the late Argentine flag sign, so you can continue the case like this case. And we have some area of capsular fibrosis or calcification. So you try to use the other hand or the other direction until you complete it. But be careful that, as we said before, that you are not sure about the same elasticity. So if you just try to rotate this case, you will find that you have, here you have a late Argentine flag sign, even while trying to rotate the lens. Again, slow motion here, wide rotation. You can find that I have a opening of the area between the calcified and the normal capsule. So conclusion, no matter what is a new instrumentation or surgical techniques become popular, the anterior rexes will continue to be an important part of cataract and the lens-based refractive procedure. Thank you very much.
Thank you very much, Dr. Ahmed. Sticking to the time. So maybe you have a question from the panel, if there is any, or I can ask you, when do you need to resort to a micro rexus forceps?
Maybe if I need to change the direction of my hand, so it's better if I have any sub-incisional extension. So in the sub-incisional extension, it's very difficult for me to control. So maybe I can use the micro rexus forceps in this situation. Or even
Okay.
in the case with calcified, it may be well-controlled rhexis.
Perfect. Do we have any questions from the panel to Dr. Ahmed? Because he finished a little bit ahead of time, so we still have, okay, we are almost done. So, it's my turn to talk about five fields for hard cataract. Hard cataract is it's a hard. Can you hear me?
Yes, yes.
Okay. Hard cataract is a challenging situation that we all as cataract surgeons, and the more experience, the more you get these patients, and you can find the hard cataract in different shapes, from brown to black to intumescent, brown or black, to Morgagnian cataract, to hypermature cataract with calcification. So we have a lot of challenges in these cases. So you have to know how to deal with it, and you have to know what you fear of. You fear of destroying the cornea, causing corneal decompensation, or injuring the posterior capsule and suffering from difficult complications that you need to deal with. So my five P's is: number one is concept, two is high magnification, three is good exposure of the phaco tip more than you are used to in regular cases. Modify your technique as I'm going to show, and I don't recommend any hydrosection in hard cataract. If you don't see the wave,
Dr. Yahya, I'm sorry for that. I can't see your screen.
you can't see the screen. Okay.
You have shared. Is anybody seeing the screen of Dr. Yahya?
Okay, I will.
Still not, just doctor.
Okay.
You don't see it?
Okay, so yeah, thank you, Ahmed, to tell me this
You're welcome, Dr. Yahya.
in proper time. So these are what I was talking about. Can you see the screen now?
Yeah, now that's good. Okay, yes.
Okay, so the challenges, you can see the challenges. And these are the fields that we want to avoid: corneal decompensation or posterior capsule rupture. And the five fields are concept, high magnification, good exposure of the tap, modified technique, no hydrosection in hard cataracts, and I will tell you why, protect the cornea and the posterior capsule. The concept, we have to remember, particularly younger colleagues, the issue is not only about removing the cataract, it is about removing it safely. It is not the power that is going to remove it. And we have to always remember where we do the phaco. And the strategy should be that we should convert a difficult case, a challenging case, into a regular case that we are used to do. So we analyze the problems and then we deal with it. The challenges, capsulorhexis, we overcome it with capsular stain. You demonstrated perfectly. The main thing is it's a thick nucleus and a hard nucleus, and that's why I do what I call two nuclei concept to save the cornea and use the least energy and be reproducible. The idea of two nuclei concept, if you have, it's like you overcome the problem of thick nucleus by shaving the upper part of the nucleus, so you are making it thinner, and then you deal with the rest of it as if it is a regular nucleus. And sometimes if it is very, very hard, I add what I call hole drilling. It's initiating, causing weakness, like causing holes in a wall that you want to demolish. This shows the steps of the technique. You do with the bevel down, decreasing the energy propagated to the cornea, shaving the upper part of the nucleus, and creating a wide crater. The secret is to create a wide crater. And with the bevel up, once you reach this 1/3, you turn the bevel up and continue as normal. It's very important to have a wide crater. Always the problem is that if you make a narrow groove, you are always afraid to go deep. And here comes the myth of gummy nucleus. There's nothing called gummy nucleus. It is not, it's only that you are not deep enough. So this, I'm going to explain it here. This is a deceiving red reflex. So you need to do a bit wider capsular axis, always in hard nucleus. Once you do your capsular axis, you see the bevel is down, exposure is large. I use the Neuhan chopper, which is used for vertical chopping, and you'll see why it is important. You shave the upper part of the nucleus in the posterior capsule, in the bag, so the propagation to the cornea is minimal. You can see the white crater allows you to go as deep as you want, as deep as you need, to go very deep, so as you can crack when you need to crack. And then I will start to do the hole drilling, like creating holes, and you can see that the nucleus rotates without hydrodissection, because it is with the fluid, it is hydrodissected automatically. And at the beginning, I don't want the nucleus to rotate actually when I'm doing the groove. You can see it's rotating perfectly without hydrodissection. And then this is the hole drilling. Don't worry, you're not going to pass through the nucleus because it is very thick, and the good exposure allows you to drill into it, weakening the nucleus. You can see the wide groove allows you to see the floor and see exactly which fibers are preventing you from cracking the nucleus. So in this way, with the high magnification, you can tell which fiber is preventing you from cracking. So you can go along the fiber. You can see here, you can go along the fiber, the last piece, to make sure it cracks. If it doesn't crack, it means there is fibers. And because you can see, because of the wide pupil, you can see well until you decrease. And you can see I'm working inside the capsular bag. And here I'm using little ultrasound and high vacuum, like 30, 40, and this stage 40% ultrasound, vacuum 450. And you can see the tip is always protected with the nucleus, and the chopper, vertical chopping, allows you to deal with any type of the nucleus under vision, even if the pupil gets down. You can see you're cracking, splitting the fibers under vision. And you can see the magnification helps you to exactly see what you are doing. It's a very reproducible thing to do. Once you crack and analyze the problem in such cases and deal with it in each case in the same concept, and improve and modifying the technique as you go along. Again, there is no ultrasound, only cracking, splitting. You can see it's almost black cataract, but I'm using minimal ultrasound, minimal effect on the cornea, and you can see the cornea is clear until the end, and you can judge the effect on the cornea on the corneal wound as well. You have to avoid corneal burn by interrupting your ultrasound. Everything is done under vision in this technique. Nothing is left for surprise. So you can decrease the amount of energy needed even in such a hard nucleus, because you divide it into smaller and smaller pieces in a very controlled way. And you can see there is no epinucleus, and exactly the posterior capsule is just behind you. So you have to be extremely careful. It is not the amount of ultrasound, it is how you tackle the nucleus, maximizing the benefit of ultrasound. You can see in very controlled technique, very reproducible technique. Most important to be a reproducible technique that we understand what's going on. So in conclusion, I wanted to say that hard cataracts with all its different forms carries a challenge. Of course, you can choose to do an extracapsular or small incision extracapsular surgery, but you can definitely do phacoemulsification even in the hardest of cataract by analyzing the problem, knowing what you fear from, and then working from there on. So thank you for your attention. And I still have 1 minute because I'm a good moderator. Hello, Yuri. How are you?
Good afternoon.
How are you?
Thank you very much. I'm
So-
fine. I'm ready to start.
Yes.
Dr. Yahya, can I ask you some question?
Yes, sure, Dr.
Thanks for this nice cases and nice presentation. What about when you decide to continue the case as a FACO, you still have the choice of extra even if you started as a FACO, or when you take the decision, so you continue because you said a good announcement about the fake radar reflex. That's right. So, I mean, is this option is still, you can put it in mind or not?
Yeah, I can put it in mind, but once you start it, it is more difficult because this, as you can see, it will be always a very large nucleus. So then if I convert, I have to change the structure of the wound and to change the capsular axis, either to do snips or make it even larger to deliver one pole of it to get it out. So it's an option, but I usually hope I don't need it, but it's an option.
Yes. Thank you.
Thank you, Dr. Ahmed.
Thank
Yuri,
you.
we are happy to have Yuri Takhatib.
It's my
And-
pleasure.
So
Are
it's
you
always
see my
nice to
screen?
see you. Yes,
That's
share
amazing.
screen, please.
Are you hearing me and you can see my screen?
No, we can hear you and see you,
Not-
but we
Not
see you.
yet. Seeing you, hearing you, but not your screen.
So Dr.
Okay.
Yuri will talk about 5 pairs in posterior capsular rupture.
Okay.
So,
We can see the screen.
very good.
Yes, now.
Yeah, very good. So posterior capsule rupture is a complication that you don't expect, but if it's ruptures, the capsule occurs in the initial step of the surgery, then you must change the plan of entire procedure. So this is the video, just a routine case. We create the rexis. We start with chopping the pieces. So we remove the piece by the normal way. And you can see suddenly the lens moved to the vitreous. So look again. It was really surprise for me because I didn't touch the capsule at the very beginning step and the material in the vitreous. Okay, what happened. But you must remove the rest of their lens masses and avoid the vitreous traction. So what the basic principle, how to manage? If you have some vitreous prolapse, first you should avoid shallowing the anterior chamber. So you keep the ultrasound tip inside the anterior chamber in irrigation mode, and you try to inject the viscoelastic inside. So stabilize the chamber. This is the first principle. Don't pull back phaco tip, lower the bottle, not irrigate too much, avoid to push the lens material back, and you should plan it out. Better if you have not only one, better if you have some 2 or 3 different plans. So the dispersive viscoelastic is very helpful to support the residual material of the lens material and protect the capsular defect to enlarge and tearing and increasing the size of the defect. And also with the viscoelastic, we're going to remove the vitreous from the phaco tip, and after that you can remove the phaco tip easily. Don't trace the lens material in the vitreous cavity with ultrasound because it's traction. Peripheral retina are very, very thin, and vitreous traction caused by the probliths, and this is very, very risky. So never try to jet-like irrigate the material from the vitreous cavity and elevate the lens material. Never use the lens loop. Also, it's very risky for retinal tears. So the main goal, you should minimize intraoperative and postoperative vitreal traction, and you should to reduce incidence of retinal detachment. So this is the first number one. If some material still in the vitreous, this is the problem of the vitreoretinal surgeon, but it's not your problem at the moment. But you should to avoid the traction. So the visco barrier between the capsular bag and the vitreous body is essential. The prevention of posterior movement of the lens material should not be the principal goal. It's important, but not principal one. But the cataract surgery patient have high expectations. So we understand that this is the problem. But this patient never expect the retinal detachment procedure. So if you have a two-step cataract surgery, it's not a big problem. But if you have a two-step cataract and retinal detachment surgery, this is surprisingly for the patient. So remember, if you have follow the plan based on a few very simple strategies, you can still get a good outcome, and the vision after the removing the residual material from the vitreous, the prognosis for the visual acuity still is very, very hard. So the primary goal, manipulating with the lens material and anterior and posterior vitreous can produce acute vitreoretinal traction, so the visco barrier should be created. Also very important, if you have a problem, you should forget about the time. You expand the time of the case. So if you are looking tonight to spend some time with the family and friends, forget about this. And nothing should be pressed for you. So keep cool your mind and don't worry. So try to manipulate by the normal way. Problem with the emergency surgical issues. Oh, you should make a decision. It will be one-step surgery or two-step surgery. If you want to have a one-step surgery on the same time, remove the material from the vitreous cavity, you should have a vitreoretinal surgeon available. Optimal equipment also should be available, and the staff should be trained with this equipment. Also, if you have a topical anesthesia, so you should ask the anesthesiologist to support. So many things you should to summarize if you want to have a one-step surgery. That is why this two-step surgery is more helpful to solve the problem. So first, you should raise the nuclear fragment above the iris plane and control the vitreous. Put the irrigation bottle low, so low flow, moderate vacuum, and all dislocated lens material needs surgery, but you should also remove the cortex. Try to avoid the cornea damage. Due to the next step for the vitreal surgery, for vitreoretinal surgeon cornea should be transparent. It will be much easier to manipulate for the vitreoretinal surgeon. Also, never use microsponge to remove the vitreous. It's also called the traction. It's very important. Many doctors try to check the vitreous, which is going outside the main incision of the side port with the microsponge. So try to avoid this. Very helpful if you try to use the triamcinolone for better visualization of the residual vitreous in the anterior chamber. Also, you can use the anterior vitrectomy probe with the special parameters. So usually I start from the very high cut rates with a low vacuum, just cut the vitreous in the anterior chamber. And vitreoretinal, when they are going down with the foot pedal, so I increase the vacuum, and at the moment the cut rates is going down. So we are playing with the cuts only and aspiration, and cuts and aspiration, and this is the very helpful how to solve the problem. So the fast cutting rate is better in all cases. Never use the aspiration before the cutting of the vitreous because you increase the vitreous traction. But fast cutting doesn't cut vitreous better, so it's not more efficient. That is why fast cutting is better, because they're decreasing the vitreoretinal traction. And anterior vitrectomy infusion option, you can use the vitrectomy without infusion, like a dry vitrectomy. But if you activate the aspiration at the moment, you cause the hypotony, and it's leading to suprachoroidal hemorrhage. So it's a risky, and meiosis, and keratoplasty, keratopathy also can occur during the hypotony surgery. So infusion fluid through the side port is a very good option. Mostly we never use the main incision for anterior vitrectomy, so we create two side ports, one for infusion fluid, the second for vitrectomy probe, and also use the low bottle because the infusion pressure increases cataport and increases the cataport pressure gradient. Also, two port iris and limbal side ports is better if you use one port. In the past, we have a vitrectomy probe with the irrigation, and we used the main incision, but it was a big problem because the vitreous and leakage stimulate the vitreous prolapse through the main incision. That is why it's very important avoid the hydration of the vitreous. So at the end, you should to remove the residual material. You can put the lens inside, even if there's some material in the vitreous cavity. And for the next stage, next step on the next day or next day, so you have time to organize everything very well with the vitreoretinal surgeon and remove the material, and still the prognosis for the patient, for the visual outcome is very good. So if you...
Yuri, I think we need to wrap up. I'm sorry, but...
this is the last slide. This is the last slide.
Excellent, excellent.
This is the last slide. So at the conclusion, if the posterior capsular rupture occurs, try to keep the control under the situation. Don't panic, and remove the residual material. Don't touch the iris and the cornea, and the two-step surgery is the preferred. So thank you very much.
Thank you, Yuri, for taking the burden to talk about the worst part of the procedure. And I know it needs 2 hours to talk about everything, but you have given us very important rules about rate of cutting, how to deal with the nucleus not fishing into the vitreous. So it really was a lot of excellent pearls. Thank you very much. And we need 1 hour to hear from you about managing this complication. But unfortunately, we have to move to the last but not least, Dr. Walid Zibeiba. Ahlan bik, how are you? And he's going to give us 5 pearls in subluxated lens.
Thank you for the kind invitation. So I has just sent my presentation with the recorded voice because we have a problem with the connection. So I think if my
Maybe
presentation
one of the technicians can
Yes.
share.
share the presentation. Thank you.
Do you want to mute the presentation or to leave it?
No.
Everybody,
Give
I
the-
hope
the-
that you are doing
okay.
well.
You can play the presentation. Ahmed, you can play.
My topic today is about the 5 pearls in subluxated lens. The major causes for unstable lens are pseudo-exfoliation syndrome, ocular trauma, myopia, ectopia lens, Morgan cataract. The management of these cases are challenging. It's one of the more challenging situations in anterior segment surgery. To build the surgical strategy and the planning of the surgery steps, we must answer 5 questions. First, we have to look after the patient age and the severity of the nuclear opacity, the extent of the subluxation lens, and finally an important consideration including whether the disease is static or progressive and the presence of the other ocular comorbidities. The main goal of the surgery are to extract the lens safely, minimize vitreous loss, followed by a stable IOL fixation. To achieve this goal, we have to success in 5 steps. First of all, capsulotomy. Second, lens extraction. Then a cortical aspiration. After that, we have to put the IOL in the capsular bag. If we lose the capsular bag, we have to choose an ideal situation or an ideal solution for fixating the IOL. Capsulotomy is one of the most important and challenging steps. Other intraoperative clues for zonal instability include pseudoelasticity, tendency for the capsular rhexis to run out. The capsule can be penetrated with cystitum and we can find star fold in the anterior capsule. The capsular rhexis size should take into consideration the need for at least 2 mm margin between the capsular rhexis edge and the equator. We move now to the lens extraction, and we have to know if the capsular bag is salvageable to do either intracapsular or extracapsular extraction. If we decide to keep the capsular bag, we have to choose the best device for its stabilization. If we choose the phacoemulsification technique, we have to determine our parameters. In this step, hydrodissection is a critical tool. It should be done carefully. We should make sure that our lens can rotate. In the phacoemulsification, we have to minimize sculpting and use fracturing techniques, use low vacuum and flow, and work in the center. Dispersive OVD, it's very useful in this case, and the key to the success is the control of the intraocular environment. During the lens extraction, we have to control the instability of the capsular bag using either iris hooks or capsular retractor. But we have to know that iris hooks are not designed for the capsula, and they can tear the capsule because they don't support the lens equator as the ends are short. In my practice, I prefer use the capsular retractors. They expand the capsular equator and provide capsular stability. The hook end is blunt and atraumatic to the capsular bag. It prevents vitreous from prolapsing forward and prevents misdirected irrigation fluid of the anterior chamber to the vitreous cavity. The number of the capsular retractor depends on the extent of zonular loss. Cortical aspiration should be done slowly, starting from the area with intact zonula. On the area of weak zonula fibers, we have to avoid polishing radially, and we have to remove the cortex tangentially. There is much less forces on the zonula, as we shown in this video. After lens extraction, we have to implant the patient, and the choice of the implantation method depends on whether the capsular bag can be preserved or not. The decision to choose to fix the bag or to fix the IOL may be based on the operating surgeon's skill, experience, and preference. When we are planning for an IOL implantation in the bag, we should use appropriate devices. CTR can expand and maintain the contour of the capsular equator. Seoneering distributes the stress centripetally across the lens equator area, stabilizing the capsular bag and centering the IOL. CTS is placed into the bag in the side or in front of the greatest zonular dehiscence, and then sutured to the sclera 1.75 millimeters to the limbus. And finally, we should avoid CTR in the presence of the incomplete capsular rhexis and also on posterior capsular rupture. The nature of the disease help us to determine the appropriate devices. It means progressive or no progressive disease of the capsula. The CTR may be inserted at any time of the surgery, after capsular rhexis hydrodissection, or even after removal the nucleus and soft lens material. The ideal stage of the surgery for CTR placement has been debated. It's recommended to place the CTR as late as you can, but as soon as you must. The CTR may be inserted at any time of the surgery, after capsular rhexis hydrodissection. The CTR may be inserted at any time of the surgery, after capsular rhexis hydrodissection, or even removal the nucleus and soft lens material. If the subluxation is severe, more than 9 clock hours, the capsular bag may be sacrificed, and choose iris fixation if the iris, and we can choose iris fixation if the iris is healthy and the endothelium cells density is over 1200 cells. The IOL may then be secured via iris fixation with iris clip IOLs, which may be placed either on the iris or behind it, like this case. And I introduced the implant via scleral tunnel to avoid corneal astigmatism in outcome. We can also choose another techniques like sutured scleral fixation technique or sutureless scleral fixation technique. For the sutured scleral fixation technique, we use acrylic IOL, foldable one, and we attached this IOL and sclera with no absorbable suture. In the sutureless scleral fixation technique, the haptics are secured to the sclera directly by fixating the haptics with intrascleral flaps panel, or grooves. We can use 3 pieces IOL for Yaman techniques, or we can use Carloval lenses. In my opinion, I prefer Carloval lens because it's the first implant dedicated to the scleral fixation, and it has a special design that gives high stability and centration. And its fixation was assured by anchoring in the sclera of 2 T-shapes haptic through 25 gauge sclerotomy placed in the sclera flap. This is a case of Carloval implantation. The IOL has a special design. Here we are placing the first anchor using the ocular forceps. We placed the first one, and then we placed the second one using ocular forceps. Then we place the T part of the plug in the scleral pocket, starting with the Velcro. This is a case of Carloval implantation. The IOL has. Finally, cataract surgery in subluxated lenses is challenging. The preoperative evaluation is critical. The extent, the location, and the etiology of zonular weakness will guide the choice of the surgical approach. Creating a good size and centrated capsular rhexis is crucial. Nucleus sculpting and heavy rotation should be minimized in these cases. The decision of the IOL implantation technique is based on the operating surgeon skills and experience and preference. Thank you.
Thank you, Dr. Walid. Very interesting, very difficult cases. Have any one of the panel used the Carlovari lens? Yuri, have you?
Never. I never.
Walid,
Look like very.
Have you used it? Dr. Durval, did you use it? Wait, unmute. Please unmute. We cannot hear you.
Sorry. I have my own technique for single piece IOL. I call it piercing technique. And I developed a micro punch that I make a hole in the middle of the haptic. And I do the 4 flange with Prolene 5.0 from Canabrava technique. So I have using in multifocal IOL and toric. Recently, I had one case that of keratoconus eye with subluxated toric IOL. I have fixated with these techniques. It's worked very well. But I appreciate the Carnival design IOL. It's very, very nice too.
Yeah, it seems it's getting popularity. I have never seen it actually in real live work, but it seems interesting. A lot of people are saying they like it very much. It's easy. But Dr. Walid, have you used it?
Yes, I have I done several cases. I know I do a scholar about the comparison between Technique Yamans and Carloval, and in the middle of the results, we have seen that that there is a visual outcome and the stability of the IOL. It's better with Carloval than Yaman technique. So really now I prefer when we have when we lose the bag or we have these cases without bag capture, I indicate the Carloval lens directly. So the problem with this implantation we have to do before the implantation whole vitrectomy. So we can't manage this kind of implantation because we tilt a lot on vitreous, anterior vitreous, and we have a lot of risk to make retinal tears. So I indicated to do vitrectomy before this implantation. It's in my opinion, yeah.
Okay, I think Dr. Safwan, how are you? Dr.
I'm fine.
Muhammad, I think we are about to end.
Yeah, just one comment for the fourth lunge. I think that I do agree with Dr. Walid that we need to do a vitrectomy to clean the remnant of the capsules and remnant of the lens, because otherwise the tilting, even in fourth lunge Canabrava, that I'm using it now more frequent than Yamani technique, any remnants, it will tilting the lens. So now I'm going back posteriorly and cleaning all the bag area from the lens matter and from the bag, and then implant using the fourth lunge Canabrava technique. And it's
Yuri,
much easier.
Yuri, what's your preferred fixation without capsular support? What's your preferred?
Me, fourth lunge technique.
Yuri.
Sorry.
Yeah, sorry. So personally, I like an artisan lens to put to the iris claw technique, and also we use the Gabor-Chereot technique because this is the benefit. This is a 3-piece normal lens. There is no need special design lens. If it's happened suddenly and you lost the zonal support, but you have a 3-piece lens, you can put it in the sclera pocket. So it's very helpful. So I like also, first time in my life I saw the surgery with this special design lens. It's looked like very promising. So we will see in the future, but my favorite technique, this is the artisan lens.
Okay, I think, Dr. Muhammad, we have to end the session because of the time. So thank you everybody for sharing, and we hope to see you on live soon, maybe in October in Mayom meeting and the presbyopia meeting. So looking forward to see you all. Thank you, Dr.
Thank you, Dr. Salah, Dr. Yahya. Thanks for everybody.
Thank you.
Thank you. Bye-bye.
Thank you very much, everyone. Thanks a lot. Appreciate
it. Thank you for the nice company. Thank you.
Welcome, Dr. Thank you, Dr. Muhammad Al-Amri.
Thank you. Ahmed Basha, thank you very much.
Thank you. Thank you very much.
Dr. Yahya, shukran jazilan. Dr. Yuri, thanks a lot.
Thank
you very much.
See you all.
Thank you, Dr. Durat. Thank you. It's great to have you with us.